Putting aside concerns about iatrogenesis, the idea that healthcare is bad for your health, basic economics says that more expenditure on healthcare should generally reduce avoidable mortality. But by how much? If the amount spent on healthcare increases by 1%, by what percentage will avoidable mortality decrease? The percentage change in avoidable mortality resulting from a 1% increase in healthcare expenditure is the spending elasticity for mortality, analogous to the price elasticity of demand, which is the percentage change in quantity demanded from a 1% increase in price. If we want to reduce avoidable mortality, say 20%, by increasing healthcare expenditure, then we need to know the spending elasticity for mortality to calculate the healthcare expenditure increase necessary to achieve this reduction in avoidable mortality. A number of policy objectives are based on meeting targets based on avoidable mortality. For example, one of the United Nations Development Program's Sustainable Development Goals is that all countries should aim to reduce under 5 mortality to at least as low as 25 per 1,000 live births, superscript 1, which reads United Nations Development Program UNDP. The Sustainable Development Goals, SDGs, Goal 3, Good Health and Well-Being 2017, returning to the text. But how should the goal be met? From expanding healthcare services or other services, and if increasing healthcare spending is to form part of the mix of policies, by how much will it need to increase? The answers to these can be obtained with estimates of the spending elasticity for mortality. While economic theory, such as the production function for health, helps us analyze the mix of inputs that may lead to improved health outcomes, it does not tell us the actual values for parameters such as the spending elasticity for mortality. To estimate the value, we must examine empirical evidence about the returns to healthcare spending, either based on variations in spending across countries or within countries over time, or both. In other words, we need to analyze the data on how health outcomes and healthcare expenditures are related. For many years, economists have attempted to address this question by considering the data on healthcare expenditures and mortality rates across countries, but such empirical research is fraught with challenges. Two of the biggest challenges concern the extensive heterogeneity across countries. The first challenge is observable heterogeneity, which concerns factors that affect countries' mortality rates that may also be associated with healthcare expenditure. For example, the income per capita of each country. This can be controlled for using multiple regression analysis as described in Part 2. Since these factors are observable to the analyst. The second and more troublesome challenge is the presence of unobservable heterogeneity. Unobserved factors may be important in the underlying processes determining both how decisions are made on how much money is spent on healthcare and how the overall level of health outcome that is attained. These factors result in causality running in both directions. Healthcare reduces mortality, but higher healthcare expenditure might be a response to unobserved factors, such as small natural disasters that increase mortality. Methods for handling this simultaneous causality are described in Chapter 12, applied to the different but conceptually similar context of estimating the price elasticity of cigarette demand.